Good evening, America. How are you? It's 4 o'clock p.m. in the Rocky Mountains, which means 6 o'clock on the East Coast. And there is but one place that you need to be, and that is Fertility with Fink and Friends. My name is Dr. Randy Fink. I am Fink, your friends. I am the clinical director of IVF services here at CNY Fertility in beautiful Colorado Springs, and we are live across the world via internet. We've got a couple of different Instagram feeds here. We've got mine, we've got CNY's, and we've got Facebook, we've got YouTube, we've got LinkedIn right here in the middle. So sure is good to see everybody on this Tuesday. Happy Valentine's Day. From last week. Wish everybody Valentine's Day last time, but can't hurt to say it again because it is that one day that everybody, well, actually, I would say that it's, for me anyway, it's that one day that people actually pretend like they like me next to my birthday. So that's the day that you have to do it. So, gosh, good to see everybody here. Folks are just stepping up here on the LinkedIn and Facebook side. Looks like my dear friend Allie was the first to join here on my Instagram. Hello, Allie. Nice to see you this wonderful afternoon, and I hope your week has been good. A special hello to Brandis, who is our nurse practitioner extraordinaire here at CNY Fertility in Colorado Springs. We've got Amy. Macro Mama says hi. Help. I thought it said hello. Oh, no, she did say, yeah, hello, not help from California. Our thoughts go out to all of our friends in California who are suffering with the weather. Gosh, it's really unbelievable to see the flooding that's taking place out there, and so certainly we are. Our thoughts are with you. Melissa is here. Happy Tuesday to you as well as to Brock Tung. Good to see you, and Layla. Let's see who we have over here on the on the CNY side first to join. Also, Brandis is over here on both. My goodness. Love Hard, Train Hard. That's a good name. I like that. That's a good one. Hi to Ashley and Anessa and Celenio 2011. Good afternoon to you. Crystal Habor. Howdy. Hello, Lou. Let's see. Ian. Good to see you this fine afternoon, and Salsa 2014. So let's see if we can jump. Well, you know what? Actually, before we jump into some questions, hi to Ariel and to Janae over there on the Facebook side. Quick mention, I think, as well, pardon me, worthwhile about some current events. Things that are going on, perhaps you have heard about, and I think that we ought to talk about them. I don't want to get into any kind of political conversation here. It's not the right place for it, but certainly I think all of us who are in the fertility world are concerned about the happenings in the state of Alabama. So apparently there is a fertility clinic in Mobile, and I actually know the doctors there. They are wonderful people, very good people. Apparently at some point a few years ago, I believe it was in 2020, they had someone break in to the facility or wander into the facility or somehow or another got into the facility in an unauthorized manner, got into their cryo storage unit, took out a tray that had embryos on it. Now, these are cryo preserved. They're preserved with liquid nitrogen. So if you touch that with your bare hands, you'll get a terrible, terrible burn. And indeed, that's what happened. The person picked them up and then hands burned. And so they dropped them onto the floor, which resulted in embryos being destroyed. Well, so that clinic, there was litigation that ensued, and ultimately this went to the Alabama Supreme Court that determined that an embryo, or what they call an extrauterine child, is still a child. And anyone who damages or destroys an embryo in any way can be liable for wrongful death. Well, what that means is that any embryo, let's say that you have a chromosomally abnormal embryo that you don't want to transfer, there's no destroying embryos. That means that theoretically an embryo that degenerates in the lab, the embryologists who are taking care of that can be held liable for really what amounts to negligent homicide. I don't know that anyone really has a full understanding of what's going to happen and how that's going to play out. But I suspect, and I certainly hope it will go to the Supreme Court. The citation in the state of Alabama included many statements from the Bible, and were really very anti. Fertility related. So I don't know honestly how the Supreme Court in this current era is going to find on that, but I do know that I think it means that a fertility clinic is going to be very hard pressed to be able to continue to operate in the state of Alabama under those circumstances. Because if any embryo that dies, the facility is at risk for either litigation for civil negligence or potentially even prosecution for murder of that the Alabama Supreme Court is calling an extrauterine child. Makes no sense that any facility could continue to operate. As I understand it, there are 5 fertility clinics in the state of Alabama, and I think they are all at risk, as are the patients with infertility in the state of Alabama. So these are indeed very difficult times. All right, so that's my commentary for the evening. Our thoughts go out to all those who everywhere, not just Alabama, but particularly in that scenario, who suffer with the desire, that longing to be pregnant, but who now have potentially one more obstacle in their way to get there. All right, Jessica is here. Jessica asks, can you talk about Provera and its use in exchange for ganirelix? Yes, absolutely. So in an IVF cycle, one of the medications that we typically use is called an antagonist. And the antagonist is either Cetrotide or Ganirelix. It's a shot that you give yourself that we start at a certain time during the cycle that prevents the ovary from releasing an egg. So we don't want your ovaries to ovulate. We don't want you to ovulate until we are ready to come and get the eggs. And at that time, we will trigger the ovulation because we want the eggs. We don't want them to get lost in the pelvis. We want to be able to retrieve them. So that medication, Ganirelix is one of them. Cetrotide is the other. They're injectable. And that's what they do. They prevent you from ovulating. Well, Provera is an oral medication that can be used instead of the injectable, and it may have some significant advantages. I actually really, really, really like using Provera in these IVF cycles because, one, it's dirt cheap. It's like $3 for a bottle of 30 of them. So you take it orally. It's one less shot to have to get. And it doesn't put a squeeze on the ovaries the way sometimes the injectables can. They have a tendency to sort of inhibit some of the follicular growth, whereas with Provera, that doesn't happen. Provera also helps to synchronize the growth of the follicles so that they tend to grow a little bit more evenly. So it has a lot of things really going for it. So I use it actually quite frequently. The downside to Provera is that, and the generic name for that is medroxyprogesterone acetate. The downside is that if you are using Provera, you cannot do a fresh transfer because it's progesterone. And as you know, progesterone is the hormone that maintains the pregnancy. How does it do that? Well, it gets that lining of the uterus ready for the pregnancy and keeps the pregnancy growing inside that lining. So we have messed up the lining by using the progesterone. So fresh transfer is out if you're going to use Provera. There are many folks who would say, well, you shouldn't be doing a fresh transfer anyway. Well, the CNY, the fresh transfer is included in the price. So if you can do it, go right ahead. There are some circumstances where we tell you it's a bad idea. We don't want you to do it because hormonally you may kind of not be in the optimal scenario for pregnancy in some situations. But across the board, a frozen embryo transfer will have a higher success rate because as I'm fond of saying, your body's in egg making mode. And if you do a fresh transfer, which is where the embryo is going back in the same cycle it was created. So the same cycle that you had your retrieval. They don't function as well because, again, think about the body wants to be making eggs, and that may at times be mutually exclusive from becoming pregnant. Nevertheless, people absolutely positively do get pregnant from fresh transfers. So at CNY, we say if you have the opportunity to do it, there's no reason that you shouldn't. There may be some circumstance where we suggest that you don't. But if you are using Provera instead of Ganirelix, you can't do a fresh transfer. But all the other reasons make it a very, very good medication as an antagonist. Hi to Roy James and pretty unique. I like that. Pretty, maybe that's unique. Pretty unique. Laura Marie is here with us today. Need anything now? Good afternoon. What TH level, TSH, this comes from Need Anything Now. What TSH do we want if the IVF patient has no thyroid peroxidase antibodies? Okay, so thyroid lives here in the neck, and it controls your body's metabolism. We generally, we have found that, and it's not we, CNY Fertility, but across the board, we're looking for a thyroid function as evidenced by the TSH blood test, the TSH, the thyroid stimulating hormone. We want that number to be between 0.5 and 2.5. The higher the number, the lower the function of the thyroid. So the higher the number, the more sluggish the thyroid is. The lower the number, I would say the higher the volume knob is on the thyroid gland. So between 0.5 and 2.5 is what we're looking for. There is some evidence to show that in patients who have what is known as Hashimoto's thyroiditis, I just like saying it, Hashimoto's. That is an evidence by what's known as thyroid peroxidase antibodies or anti-thyroid antibodies. It's an autoimmune situation where your body forms an antibody, forms an immune response, pardon me, against your own thyroid gland. Some people have this, and their thyroid function can be normal, but we do in general try to, or many of us believe that we should try to keep that TSH level around 0.5 to 1 in someone who has anti-thyroid antibodies, because that can decrease the risk of miscarriage. But in general, we're looking for a TSH to be between 0.5 and 2.5. Hopefully that answers that question. Ariana asks, does a 5.53 AMH indicate PCOS, and what would cause that to spring up out of nowhere? Well, yeah, so generally when we see an AMH or an anti-Mullerian hormone level that is above a 5, we consider that to be consistent with ovaries that will behave as polycystic ovaries. Now, there is such a thing as polycystic ovarian syndrome, and I'm sure that you've all heard of that, PCOS. Polycystic ovarian syndrome requires a couple of other things. It requires some laboratory abnormalities, such as your androgen levels, your testosterone, or the male hormone levels typically are a little high. This can result in hair growth where it's not supposed to be. It can result in acne. Classically, women with polycystic ovarian syndrome are anovulatory. They don't release an egg, so they don't get a period. And it's associated with some markers of insulin resistance. And that's the syndrome. Everybody with polycystic ovaries does not necessarily have polycystic ovarian syndrome. So when I say polycystic ovaries, we can look at the ovaries, and it has a sort of a characteristic appearance. It's what we call the chain of pearls appearance, and that is multiple peripheral follicles. They kind of, pardon me, they kind of line the outside of the ovary. And that's a PCOS, or lots of little follicles on the inside. That's what we call it, a PCO-looking ovary. And so if I saw an AMH of 5.53, Ariana, I would say, yeah, I think your ovaries are probably going to respond like they are polycystic ovaries. What does that mean? Well, women who have higher AMHs like that, or women who have polycystic ovarian syndrome, or even those that we're calling in this other class, the ovaries respond like polycystic ovaries, the ovaries typically pay very close attention to the medications we use. You typically get a very robust response to stimulation. That's not a bad thing. That's probably a better thing than not enough response. But when you get too much response to medication, that results in ovarian hyperstimulation syndrome. So, usually, in a woman who has a higher AMH like that, we typically lower the dosage of medication to keep you from becoming hyperstimulated. So, how do we decide what dose of medication you use for IVF? Well, first of all, it goes back to your age. So, based on age, we can usually determine how we expect the ovaries to respond. The secondary marker is with that AMH, which may make us increase or decrease a dose depending on where it is. So, that's kind of how we know. And how does that spring up out of nowhere? Well, I don't know what it was before, but there is some variation in AMH. It can change over time, both positive and negative. Now, typically in nature, we see the AMH levels start to go down over time as we mature. Hi to Leah Schmink. Nice to see you. Oh, look who is here. My beautiful mother in Lower Alabama. Speaking of Mobile, Alabama, and I guess my father is not too far away. I am so glad. So, mom was sick and in the hospital last week, and came home just very recently. And her baby boy Randy is going to visit on Thursday, so I will be in the great city of Mobile to see you. So you better get on your P's and Q's there, Missy. Barbara Brown is here. Barbara says, can an AMH be drawn at any time, even if pregnancy has occurred or pending? So an AMH is not considered to be cycle dependent. Doesn't matter when during the cycle you draw it. And yes, theoretically, it can even be tested during pregnancy. Be honest with you, I'm not sure the effect of pregnancy on an AMH, but unlike the marker that we used to use was a day 3 FSH, the FSH hormone, and it really needed to be done in the early portion of the cycle, which was kind of day 3, and that was what we would use to sort of determine ovarian reserve or to predict how the ovaries would respond. Well, now AMH is said to be a more reliable marker and can be tested at any time during the cycle. Hello to all our friends over here on the Facebook and YouTube and LinkedIn side. Ariel says, I am 30 weeks with my CNY baby. Congratulations. That is awesome. We have a filamentous cord insertion, and I am stressed about it, but my doctor doesn't seem to be. He thinks whatever happens, happens. So a filamentous insertion of the cord means that rather than being the umbilical cord, rather than being plugged into the to the substance of the placenta, sits a little further out. In general, it may even be completely unrecognized, even at the time of delivery. A more concerning problem would be something that is known as a vasa previa, and that's a potentially life-threatening kind of problem. But a filamentous insertion, I think you're in okay shape there, Ariel. And congratulations, 10 more weeks to go to delivery date. That is exciting. Scott and Mel are here from upstate New York and have a question. They say, I had an unsuccessful IVF with a negative beta on Valentine's Day, February 14th. I decided I wanted to do another treatment immediately. I started my period on Sunday, the 18th. I have my beta blood test and ultrasound tomorrow, the 21st. Is it too early to start another cycle? So I think what you're talking about there, when you said an unsuccessful IVF, if you did a retrieval and then You're going to get your period probably 10 days after the retrieval, or maybe you did a fresh transfer as well, and that didn't work. Well, probably 10 days or so after the retrieval, you're going to get your period. If you start a stim in that next cycle, that's what we know as a back-to-back cycle or a stacked cycle. And that is, uniformly speaking, a good thing. Why is that? Well, the medication that you used, let's say that you used in January, will continue to help you to recruit eggs in that February cycle. So that's a good thing to have there. The medication kind of figure your body knows what to do, so it just does it better in the next cycle. If what you're talking about there, Scott and Mel, was that you did an embryo transfer, like an embryo transfer cycle that was unsuccessful, you had a negative beta, and then you get your period, there is no harm in going directly into another embryo transfer cycle. There's no advantage to going into another embryo transfer cycle, like there is an advantage in doing another retrieval. Stacking retrievals, there is an advantage to egg recruitment. Stacking transfers doesn't harm you, but nor does it necessarily help. So not sure what you did there, but hopefully that will answer your question. Joan Delgado, this is not working. I've tried 2 times and nothing. And well, I will tell you, very healthy and everything fine. And I pay too much money for nothing, got the baby. Well, so Joan, I think what we need to understand here, and I'm not sure what kind of treatment you did, but fertility treatment is not a perfect scenario by any stretch of the imagination. If you're doing IVF, IVF is a numbers game. It's about maximizing the number of eggs that you can retrieve so that you can maximize the number of embryos that you can make so that you can maximize your options. It's a numbers game. It's about getting, remember the egg that's in the ovaries, your eggs, you were born with all the eggs that you'll ever have. The sperm that comes out today was manufactured about 3 months ago, but the eggs in the ovaries, they have been there for your entire life. And so the DNA in those eggs becomes less stable over time. So we tend to make these embryos, or we tend to produce eggs and create embryos that are not normal. And when they are not normal, they typically don't implant. So that's the most common reason that someone doing IVF is unsuccessful with that IVF. It is a hard and unpleasant process, to say the least. And I think, Joan, everybody watching the program today can tell you, it's tough to go through. Certainly wish you well. Other things just to mention there, if you're doing something that is less effective, like an IUI, well, an IUI, it just, sometimes people will say to me, well, we did 3 IUIs and they just didn't work, so something is wrong. And I would say, no, not necessarily, because an IUI, or an intrauterine insemination, has a success rate of about 9% per cycle. So if it doesn't work, how many cycles, if it's 9% per cycle, how many cycles do you have to do before you get to 100%? That's a lot of cycles. And that's way more IUI than anybody ought to be doing, because after 3 to 5 cycles, it's probably no more effective than home intercourse at that point. So we don't recommend it. IVF is the fastest path to pregnancy, is the most successful path to pregnancy. But again, even with a euploid embryo, which is the best case scenario we can get, it's a 65% probability for that first embryo. So it's not 100%. And that is a tough pill to swallow. But our thoughts are with you there, Joan. Know that this is a difficult roller coaster to ride, but you are not riding it alone. For sure. All right. What else we got going on here? All our friends are here this afternoon. It is such a good thing. JM Dot says, I hope you're feeling better. Thank you for saying so. I'm still, I've got this 3-year cough apparently. So humidifier seems to help, but I still sound so sultry. And that is what's important, Let's see here. Thanks for addressing what's going on in Alabama. Yes, indeed. Here comes from Rare Soul. I have a question. So I'm still waiting. Cycle day 1. I took Prevera for 5 days and missed 2 days, and then took the remaining 5 and still haven't gotten my period. What could be happening, and what should I do? Well, so Provera, like we talked about as an antagonist in the IVF cycle, is also a medication that we can use to induce a period. And it sounds like that's what's going on with you. Usually that happens, or usually we induce a period in someone who has not released an egg. So if you don't ovulate, so let's look at normal circumstances. Normal circumstances, your ovary releases an egg. That egg hangs out and waits for sperm to come along and fertilize it. And if it does, it says, woohoo, we're pregnant. And the brain says, all right, we know exactly what to do. Now we're pregnant. Do those things. If not, the brain says, oh, all right, dang it, we're not pregnant. So shut off the hormones, clean everything out, and we're going to start again fresh next month. And that's the signal to have a nice normal period. Well, if you don't release the egg, you don't get the signal. And if you don't get the signal, your body doesn't know what it's supposed to do. And so sometimes you'll bleed and bleed and bleed and bleed. And that's what's called anovulatory bleeding. Or sometimes you just won't have a period at all. And that is as a result of anovulation. Ovulating is releasing the egg. Anovulation is not releasing the egg. So what can we do? We can give you some progesterone. That progesterone level goes up and then it drops down. And when it drops down, that's the same signal as the body normally has to say, oh, we released the egg, didn't fertilize it. And so now what do we do? And so what do? You have a period. That's how we induce a period. Not quite clear that, well, you missed a couple of days there. And so you have to have a sufficient level of progesterone in order for, once the level drops down, for that to work to induce a period. So that may have been one thing. Personally, I usually, instead of doing 1 pill a day for 10 days, I usually write that for twice a day for 5 days, because it gives you, first of all, you're done with it a little sooner, but it gives you, excuse me, the sufficient level such that then as it drops off, it'll induce a period. If you don't have enough estrogen in your body, then you won't get the period. Sometimes instead of using the pill, we may also use a shot, the PIO shot, to induce a period. Usually that's about 75 milligrams to induce a period. But the next step in the evaluation is that if you, depending on what your situation is, if we don't know otherwise, there's some blood tests that we might check. We check your FSH, we check your thyroid, and we would check your prolactin hormone. Then, if we didn't know what else was happening, we might give you a bunch of estrogen to build up your lining, and then give you the progesterone and see that you have that, which we call a withdrawal bleed. So I suspect your period will come along here, if I had to guess. Good evening to That's Akira. I like that name. Let's see. Does Omnitrope, this comes from Salsa 2014, does Omnitrope make a big impact on egg quality? People say there's no scientific evidence, but I hear a bunch of women's stories and they say it works. So, you're absolutely right there, my friend Salsa. The use of growth hormone is quite controversial. Why is that? Well, there have been some studies. So what is growth hormone? So the medication that we normally use for growth hormone is called Omnitrope. In the anti-aging community, we use growth hormone. In the weightlifting community, they use growth hormone. Growth hormone is what keeps us young. So as we mature, our own innate growth hormone levels go down. So that's one of the things that causes aging. So if we give you some growth hormone back, we may be able to keep portions of you younger. Which portion in particular? The ovaries. So how does growth hormone work? Well, nobody's really 100% sure, but at the level of the ovaries, it may be able to help your body repair some of the age-damaged DNA. I am a believer in growth hormone, but because I too have really seen it make a difference in folks who have diminished egg quality. But there have been some studies that show it is just an expensive addition that really doesn't do anything. It doesn't increase the live birth rate. Just like there have been some studies that show that it does do something. So many practices don't use growth hormone and won't prescribe it for you. At CNY, we do very freely because I do believe, and we do believe, many of us believe that it does make a difference. There has been some difficulty in the manufacturing side of growth hormone. The one we use is Omnitrope, and that Omnitrope has been hard to get in some of the pharmacies. There are also some alternatives to Omnitrope. So if you are prescribed Omnitrope and you can't get it, please reach out to our prescription team who can take care of making sure that you get one of the alternatives that are available. It is expensive. That's the only thing. And I wish it wasn't. Now, since we're talking about Omnitrope and growth hormone, there's something else I really want to mention here because I feel very strongly about it. There is a supplement that's called Serovital. I mentioned this last week and I got some extra follow-up questions about it, so I think it's worth mentioning again. Serovital is something you can get at Costco, for instance, and it's an herbal. It's a supplement that is said to increase your growth hormone level. And if you're taking it for anti-aging purposes, it makes definitely, I've taken it before, it makes for better hair and skin and nails. And that's not a bad thing. But it has not been studied in the fertility world. There are many of us who recommend Serovital as a supplement to be taken for people who can't get a hold of growth hormone or for whom growth hormone is too expensive or for whatever reason. However, Serovital's principal ingredient is an amino acid that is called L-arginine. L-arginine is associated with poorer egg quality. It's associated with decreasing the quality of the eggs and with promoting the chaotic and irregular dysynchronous growth of the follicles in the ovary. So even though some well-meaning folks will recommend Serovital as a supplement to take to increase your own growth hormone levels, because growth hormone in theory should help us, L-arginine does not help us. And since Serovital has not been studied in fertility, we don't know if the effect of boosting the growth hormone exceeds the effect of how L-arginine can actually harm egg quality and follicles. So I think most of the folks who recommend it may not be aware of that data on the L-arginine. I strongly encourage you to please not use Serovital as something for egg quality, even though your provider or someone on the phone, one of the nurses, might have recommended that you do so. Let's see what else we got here. Mag Scambor says, can you continue an IUI if it is the side of the blocked tube? If you're ovulating from the side of your blocked tube. I know the tube can pick up the egg from the other side. Potentially, the answer is yes. So, let's go back to my friendly neighborhood uterus here. Hello? Wait. Hi. Okay. So, the uterus is depicted like this, although perhaps without the smiley face, that the tube is out here, and the ovary is over here, and the egg has to kind of go in that side. Well, in the body, when the woman is standing up, the tubes are actually sort of sitting kind of down here in the pelvis, and so when the egg gets released, it does have the potential to be picked up by the other side. So if you have one blocked tube, it does not mean that you can't do an IUI when you are ovulating from that side. It means that you can. So hopefully that answers your question there. Howdy from Texas. Amy G. Jess says, really, really glad you're talking about this right away. I guess we're talking about Alabama there. My pleasure. Praying for those who were affected. Yes, indeed. Let's see. Just Fame Music says, wondering if AMH can fluctuate drastically depending on if tested during the follicular versus the luteal phase. Mine went from 1.9 to 0.83 in 12 months. That really shouldn't matter. You know, what time during the cycle you are testing it shouldn't make a difference. But it does go down over time. And if you have been doing fertility treatment, if you are on some birth control, that can artificially lower that AMH. But I agree, sort of basically cutting in half there over 12 months is a lot. So I might think about retesting that, my friend. Let's see. Lex Blackwell, hello. Consult. It just face says consult is on March 13th, coming to Colorado for treatment. Outstanding. We're always happy to see you here. Look what happened there. I got a thumb up. I don't know how that happened. If someone has a delayed cycle after tubal removal, are they okay to start IVF in the next cycle, or should they wait for a cycle in between? So I guess what you mean there is that you had your tubes taken out, or a tube taken out, and the stress of that on your body can affect the way your ovary releases an egg. So it may mess up your period. Generally speaking, we find that, yeah, we can start an IVF cycle at any time during the cycle. So for instance, sometimes patients will come to us maybe who are diagnosed with cancer, who have a hard stop on their date because they're going to be starting chemotherapy. Well, in that situation, we may start your IVF at any time during the cycle. But when we do that, it does decrease the yield in the number of eggs. So generally, it's better to start at the beginning of the cycle if you can. Let's see here. Camilla over on the Facebook side says, first time doing IVF. My first baseline ultrasound is tomorrow, and I'm so nervous and excited at the same time. And I think that is completely understandable because it is, I described it before as it's a roller coaster. And so if you've been to the amusement park and you get on that roller coaster, you are both excited and nervous as the bar comes down to hold you in, and the train is released from the station. So yes, indeed. My AMH is 0.99, and we also have male factor. Hope this will be our shot traveling to Colorado Springs sometime in the next couple of weeks. Camilla, we're looking forward to seeing you here, and that is fantastic. Ashley Steed says, Charleston, South Carolina. Good evening, Charleston. I was diagnosed with a hydrosalpinx in my right fallopian tube. Should I remove it? Fun fact, I have a consult in April in Albany. All right, so the answer is yes. A hydrosalpinx is fluid that is in the fallopian tube. Oftentimes what happens there is that the tubal may get blocked on its far or distal end, and it starts to collect some fluid inside, and it can grow. They can grow actually pretty big. These fluid-filled tubes, that fluid is very frequently toxic to an embryo. So when we find fluid in the fallopian tubes, we will always recommend that be treated. Now, you can remove the tube, which I think is probably the easiest thing to do, but you can also just put a blockage on the near side of the tube so that fluid can't flow in. I think if you're going to the trouble, you might as well just remove the tube, because sometimes those fluid-filled tubes can also cause pain. They can hurt. So I think it's probably better to get it out. Let's see here. Could we discuss, this comes from Charlene, the ERA, the Emma, and Alice? Yes, indeed. So an ERA stands for the endometrial receptivity assay. It is packaged with with two other tests, and the three together they call the trio, or the endometrio, like the endometrium, but the three tests of the endometrium. We used to think that the ERA was a very valuable test to do, and it was part of the standard workup when you had a recurrent implantation failure. So that means that you kept doing embryo transfers and you weren't getting pregnant. After a couple of them, we would say, let's think about doing an ERA. So the idea of the ERA is that Um, um, it was thought that 75% of people all had the same implantation window. That is, there's a period of time during which the uterine lining is receptive to an embryo being transferred, to being put in. 75% of us fall into that same window, which means that 25% of us fall outside of that window. And really, what we're talking about here is the amount of time that you get progesterone in a medicated cycle before the embryo goes in. 120 hours plus or minus 3 of progesterone is where 75% of us would fall. So if things were just never working, we could do a test, the ERA, to see when your individual receptivity window is, because maybe you're in that 25% that's not at 120 hours. And that sounds like the greatest idea ever, doesn't it? Well, the problem is that when they studied that fairly recently, in the last year or so, we found that the ERA really doesn't improve pregnancy rates. It doesn't increase live birth rates. We still will reserve it for folks who really, really should have been pregnant. Like, let's say that you did 4 euploid embryo transfers. At that point, you have greater than a 99% probability of being pregnant. And if you're not, and we're starting to run out of ideas, what else could be going on? We will often recommend the ERA in that scenario. But otherwise, an ERA in general is no longer recommended. It has really been debunked as not such a great test after all. The Emma and Alice test are designed, and they could be done together. This is all done through a little endometrial biopsy. A little straw goes inside the cervix, sucks out a little piece of tissue at a particular and specific time during the cycle, and can be tested. So in theory, what they're doing is they're testing the uterine microbiome. So they're looking for different types of bacteria and stuff on the inside of the uterine cavity, which theoretically can affect the way an embryo implants. Well, as it turns out, that's probably not so critical either, because it's a very expensive test. I think it's about $900. And you can probably, really get kind of the same information with a simple endometrial biopsy that can be done at any time during the cycle that your insurance will also cover, looking for something that's known as chronic endometritis, or a chronic inflammation inside that uterine lining. So ERA analysis, in the olden days, there were some practices that would say you have to do the ERA before we'll even transfer even one embryo, because we're trying to maximize the chances of success here. Well, they studied that too, and they found that in the general population, it was not worthwhile. It did not improve pregnancy rates at all. And so that really fell out of favor. Or there were some practices that still do it, but probably did it for, maybe for billing purposes instead. But now the ERA is no longer considered to be something that is really a mainstream standard of care. Let's see what else we got here. Hello, Lou. Helulu. Maybe I'm saying it. That's better. Helulu. I don't know if I'm saying it right, but it's fun to say anyway. If someone with endometriosis wants to retrieve a lot of eggs, can they do a standard medicated cycle, or is a mini cycle recommended? So yes, the stimulation portion of IVF with someone who has endometriosis typically doesn't so much change. That we would use the medications that are most appropriate given your age and your AMH. Now, endometriosis can affect your AMH level. It can lower your ovarian reserve, and that's one of the ways that it can stand in the way of folks getting pregnant. Another way is that it affects implantation of an embryo. So if we know that you have endometriosis and we make embryos, we will generally want to recommend that you suppress that endometriosis for 60 days with some medication before doing your embryo transfer, because that gives you the best odds of pregnancy. But a standard medicated cycle, if that is the appropriate dose for age, yes, indeed, Helulu is a fine, is a so fine. Let's see what else we got going on here. I saw, is a saline sonogram necessary? Well, you can always um, um, decline to do it. A saline sonogram is a test where we place a little straw inside the uterine cavity and place a teaspoon of fluid on the inside while doing a vaginal ultrasound. And in so doing, we can see the inside of the cavity so that we can know that there are no polyps, that there are no fibroids, that there's no scar tissue, that there's no bands of muscle, that there's nothing that is going to prevent your beautiful, perfect embryo from implanting. Um, I very firmly believe that evaluating the cavity is something that should be done once a year. And that can also be done with a hysteroscopy. So some of our centers, we will do a hysteroscopy. In Albany, they don't, but in Syracuse, Colorado, Sarasota, we will do a hysteroscopy, which is where a camera goes inside and we take a look at the time of your egg retrieval. So while you're already under anesthesia, so that you don't have to feel anything and don't have to have yet another radiologist kind of fiddling around with your cervix. So is it strictly speaking necessary? And well, in my opinion, you're really investing a lot to make these beautiful embryos. And so I think it's really important to know that the place that we're going to put that embryo back is just as beautiful and perfect as the embryo itself. So in that regard, I think it is important to evaluate the uterine cavity either with a saline sonogram or a hysteroscopy. Now, you can decline it. You can say, nope, I refuse to do that. That's your embryo, and we won't refuse you care, but understand if then later on we find there's a polyp that was preventing everything from working, well, not much to say at that point. Let's see. Vanessa on Facebook says, that was the question about Provera. We already talked about that one. Hi to Janae. I have adenomyosis and my consultation back on the 1st of January. When should I expect a follow-up call so I can get started? Well, Janae, once you have your initial consultation with CNY and there's a plan put in place, we are waiting for you. Generally to get your period. I don't know what plan was put in place for you, if it was for IVF or for an embryo transfer, but generally speaking, we are waiting for you to get a period so that you can let us know when you are ready to start. So simply portal message. If you are one of our global patients, message the global travel nursing team. If you are seen and cared for or local to one of our offices, then a portal message to the nursing team in that office. Let's see, what time is it? 47 minutes after the hour. So we have about another 15 minutes here on Fertility with Fink and Friends. So glad to see you like every Tuesday evening. One of my favorite places to be. Allison Justice asks, we talked a little about the TSH before and how we're looking for that to be between a 0.5 and a 2.5. And Allison asks, if the TSH is higher than a 2.5, do I need to take thyroid medication? In general, we do recommend it. We would typically start you on the lowest dose, well, depending on what your thyroid is. If you are overtly hypothyroid, like let's say that your thyroid hormone level is a 9. So, anything above about a 4.5 or so is considered to be clinically hypothyroid. Hypothyroidism is a disease. It's a sickness that needs to be treated. And in that situation, we would start you on medication. Usually the medication dosage is weight-based. But if it's just that, let's say your TSH was 3.4, yeah, we want that to be that TSH to be a little bit lower. We want to kind of turn up the volume knob on your thyroid. And so usually we would start you on the lowest dose of thyroid, which is 25 micrograms if you're using levothyroxine. There are other types of thyroid that we can use, but typically, yes, we would want to increase the function of your thyroid a little bit in order to optimize your fertility. Kelly says, I did IVF initially. The first FET ended in a chemical pregnancy at 5 weeks and 5 days. A chemical pregnancy is an embryo issue where the pregnancy implants, you get a positive pregnancy test, it starts to go up, but then it realizes something is not right. And so it reverses the process and starts to go back. That's what's known as a chemical pregnancy. My second FET resulted in my 2-year-old child. Outstanding. The third FET failed. The fourth FET ended in a miscarriage at, 16 to 17 weeks. That's very hard, that second trimester loss there, Kelly. I'm so sorry to hear that. That was in August of 2023, and everything was normal. The pathology of the tissue was normal. Unsure why I had a miscarriage. I am all out of frozen embryos. I can't afford another round of IVF and would plan on doing an IUI this summer. Would the medication protocol for the IUI be similar to an FET, or is it something completely different? So first of all, I would want you to really talk about that with your OB to make sure that this is not an incompetent cervix, that there's not something about the cervix that doesn't want to hold the pregnancy inside, because there are things that we can do about that. Medication for an IUI is typically just ovulation induction. So we give you some, usually letrozole, for 5 days. Letrozole will make sure that your ovary releases an egg in a timely fashion. We can trigger your ovulation so that we know that we can get sperm inside at just the right time in order to maximize the opportunity for sperm to be able to meet egg. That's usually how that medication goes. We typically use a little extra vaginal progesterone in an IUI cycle to help support the pregnancy. Kelly, certainly hope that turns out to be happier times ahead for sure. Vanessa is with us this evening. I have a question. We answered that question already. That's about the progesterone. What else we got here? A low AMH and a low FSH. Should I respond well to low stim meds? That comes from Camilla. And the answer is yes. We tend to go with lower doses of medication. Although if your FSH is low there, Camilla, I would, probably, rather than saying, oh, hey, let's use a mini dose in you, my preference would be to say, let's use an age appropriate dose in you, so that at least we can try to maximize your outcomes. Perry, looks like Perry Myslova can bring cold after FET affect your FET success? Waiting for Uber for too long, and now I'm freaking out. Can being cold affect your? No, because your core body temperature is pretty well maintained at a very stable kind of range. Now, if you were out in the Arctic and you got hypothermic, or you fell through the ice in a lake and you were soaking in water, you get hypothermic in a matter of minutes. That may have an effect on you, but waiting outside in the cold a little bit too long because the Uber was late, no, that shouldn't have any adverse effect on your embryo transfer. Can you do a natural FET without progesterone support? My levels got really high in my failed FET, and the side effects were tough. I've always had good natural levels. Well, the data shows us that using in a natural cycle FET, which means that you are making your own estrogen and progesterone, we're not giving it to you. The data shows us that if we give you a little bit of extra progesterone support with vaginal suppositories, it improves the outcomes. However, if your progesterone level is adequate, if we look for it to be above a 10, in a natural or a modified natural cycle for FET, then yeah, you don't have to use the vaginal progesterone if you don't want to. That's your call. Now, there are some people who do a medicated cycle and they say, no, I don't want to use that progesterone and oil shot. I don't like it. It hurts. You're absolutely right. It does. I don't want to use it. Then I would tell you, don't do a medicated cycle, because vaginal progesterone only in a medicated cycle is not enough to reliably get you pregnant. In that scenario, you're not making any progesterone on your own. In a medicated cycle, we have to give it all to you. So then you really do need that extra progesterone shot. In a natural cycle, there's no shot. You make your own progesterone, and you could skip that vaginal progesterone if you wanted to. Over again here on the CNY side, how many aneuploid blasts have been transferred and the baby came out okay? I know Mosaic can correct, but do you have any cases of an aneuploid? Absolutely. So PGT testing is not a perfect scenario for a couple of reasons. One, they're biopsying from the portion of the embryo that becomes the placenta. That's what's known as the trophectoderm of the embryo. You can have an abnormal placenta with a normal baby. So it's said that 15% of aneuploid embryos that are, biopsied, PGT tested, aneuploid or chromosomally abnormal embryos on report are actually chromosomally normal. The mosaic embryo has a little lower chance of success. It has a little higher risk of miscarriage, but it's still better than an untested embryo, and if it sticks and grows, it has just as high a probability of giving you a normal baby as does your euploid embryo. So we had a lady who came to visit us here. Well, it's been a little while now. It was probably about a year ago, whom right when I started here in 2021, had transfer. She didn't feel good about destroying embryos. She had aneuploid embryos, and so she opted to transfer 2 aneuploid embryos, which we did. And in fact, a year later, she came in to show us her completely normal twin boys. They both stuck. They were both false positives on the PGT testing. So yeah, it absolutely can happen. 15% of the time is what they say. Is an AMH, this comes from 90, is an AMH the only way to diagnose diminished ovarian reserve? And what is the average AMH for a 37-year-old? So there are some nomograms. You can look up AMH curve on the internet and can kind of plug in, sort of track down the number that age that you're looking for and really see exactly where that falls. My gestalt would be, probably 37. I'd say maybe about a 1.8 or so, just roughly speaking. And AMH is the way that we diagnose diminished ovarian reserve. So there are some secondary ways you can look at what's known as an antral follicle count, and that's where you do an ultrasound in the beginning of the cycle and see how many follicles you have hanging out there. And if there aren't very many, you may say, oh, this looks like diminished ovarian reserve, because if there's above 5, that's said to be normal. We don't really use that so much anymore because the AMH is really a more reliable indicator of how you're going to respond to your IVF cycle. Let's see. When should you request for 2 embryos to be transferred? I had my baseline scan for the transfer. When the team contacts you to actually set up your embryo transfer, there is a form that they will fill out that indicates what your request is. Let's see what else we got here. Going back to mine. Any tips for getting lining trilaminar? Mine lining is thick enough, but not trilaminar prior to triggering ovulation for a modified natural. Thoughts on Viagra or suppressing to give me more time? Viagra is a good thing to do. It does increase the blood flow going to the uterine lining, as well as L-arginine. L-arginine, which we talked about before, is one of the recommended supplements for embryo transfer that is not used during egg retrieval, or not for stimulation, not for egg quality. It works against you for egg quality, but it has definitely an effect on the growth, the growth of the lining, to try to make a 3-layer lining, and that's a trilaminar lining. And really, it's not so much 3 layers, but what it is there's a top layer, there's a bottom layer, and there's an interface between. And that interface, you see a little line there. So it ends up kind of looking like, I heard it once described as Mick Jagger's lips. So you see a top layer, you see the middle, and then you see the bottom, the top lip, bottom lip, and then the layer in between. That's trilaminar. So that's going out to Leah, and good luck to you and your endometrium, my friend. Let's see if we can get one more question here from the Facebook side. I had a tubal reversal. This comes from Nancy, followed by an HSG 6 months later that showed one tube open and the other flow stopped near the fimbria. Is this more likely truly blocked or a spasm? Well, if you have one tube blocked on an HSG, in general, we say there's a 60% probability that that is just a tubal spasm. However, if you had surgery to unblock that tube, there's a greater probability that that tube may have scarred down again. Now, the blockage was near the fimbria at the end, and the tubal ligation is someplace else. It's a little kind of around the mid portion of the tube. So, I'd say somewhat equivocal, but the good news there is that with even one tube, even if you remove that tube, one working tube gets you the same level of fertility as if you had two. So there you go. Hey, folks, top of the hour here, which means we are about out of time for another Tuesday. So good to be with you as always. Life throws us its ups and downs, and it's hard to stay on the straight and narrow and to feel positive about things all the time. But we're in this together. And I would say, just like the sign says behind me, try to, lead life with kindness, lead life with love, and move forward with hope, because every day brings the possibility of new things. This whole business about infertility is not your book. It ain't your novel. It is only a chapter, and we are here to help you rewrite it. God bless everybody. Thanks so much for being here. I'll see you next week. Good night.